To the final part of this lecture, which is how to read ECG in a rapid way in the ER. Using this focused approach, we are have either a scenario of ischemia or a scenario of arrhythmia. If you have a patient presenting with chest pain, the rapid look will be for the Q wave, ST segment, the T wave morphology, and then localization of any abnormalities of these waves. On the other hand, if we have a patient presenting with palpitations and we are suspecting arrhythmia, the most important items to check rapidly is the rate, rhythm, the B wave QRS complex relationship, and the QRS duration, as we will explain in the coming slides. Here we have a 46 male patient presenting to emergency with chest pain. So following the rapid ischemia approach, we will check for a Q wave. Then we have here and here and here, and also in V4 a deep and Q wave, which is pathological Q wave, B1, B2, B3, and V4. Rapid look for the S segment, we have ST segment elevation in comparison to the following TB segment, and the elevation is much higher than 1 millimeter. It is about 5 or 4 millimeters, so it is significant S segment elevation. The T wave, we have inverted T wave in the same leads. So the diagnosis here, we have an S segment elevation on the septal and anterior leads, denoting anterior or anteroseptal S segment elevation myocardial infarction. And here is how we localized the site of infarction. V1 and V2 is recording the septum, V3, V4 looking at the anterior wall. So we have anteroseptal stem. Now we have a 65 male patient presenting to emergency also with chest pain, again with the rapid protocol, looking for any pathological Q wave. We don't have. Then the ST segment, we have ST segment elevation here in lead 2, lead 3, and EBF, and we have what is called reciprocal depression on the opposite leads, lead 1 and EBL. And regarding the T wave, we have also inverted T wave here and here. So we have inferior lead 2, 3, EBF, ST segment elevation. And as we said, 2 and 3 and EBF are looking at the inferior wall, so this patient have inferior S segment elevation myocardial infarction. Then we have what is called MI equivalent ECG. That means that the patient don't have S segment elevation, but still he has a high probability to have significant myocardial ischemia. We will go through this MI equivalent ECG rapidly, starting with what is called the Winter sign. The Winter sign denoting acute myocardial infarction or ischemia on the left anterior descending artery territory. The Winter sign defined by the breast jaw point, or the terminal part of QRS complex is depressed, followed by hyperacute T wave, like this T wave more than 2 large square. The presence of the breast jaw point and hyperacute T wave on the precordial chest lead, denoting proximal left anterior descending artery ischemia, and this mandate a rapid invasive pathway of management, as seen here. The second important equivalent of myocardial infarction ECG called the Wellen syndrome ECG. It denotes significant proximal LAD lesion with spontaneous revascularization. It has two types. Type 1 defined by deep symmetrical T wave inversion in the precordial leads, like this one, and type 2, which entail a biphasic T wave on the precordial leads, like this one. If we see this pattern in a patient presenting with acute chest pain, even if the chest pain resolved, we should underwent invasive approach with urgent coronary angiography for such patient. And finally, when we have a diffuse ST segment depression in different leads with ST segment elevation on AVR, this is the first time to mention AVR, this denotes a marked subendocardial ischemia on a large area of myocardium. This usually seen in a patient with left main artery or multi-vessel disease lesions. So again, this type of ECG with diffuse S-segment depression and S-segment elevation in AVR mandate a rapid invasive pathway of management. The final ECG that might be missed on the emergency, if we have a patient with acute chest pain and the ECG looks like this, we have a tall R wave. As we remember from the morphology of QRS complex in V1 and V2, it has small R wave followed by deep S. Here we have a tall R wave on V2 and also predominantly in V2, followed by deep ST segment depression. This might denote what is called the posterior wall myocardial infarction, because the posterior wall is away from the surface ECG. So myocardial infarction, this wall might cause a mirror image on the anterior chest lead. That means if we record the electrical activity on the posterior wall, this will be the mirror image if we flipped this ECG and looked at these leads. This tall R is actually a deep Q, and this S-segment depression is actually a segment elevation on the mirror on the posterior wall. Isolated posterior myocardial infarction might be seen without inferior S-segment elevation, commonly seen with inferior elevation, but isolated might also be seen and easily missed. So how to confirm that this ECG pattern is a posterior myocardial infarction? The simple way is to flip the ECG and looking from the back of the paper, we will see that this tall R and S-segment depression is actually a Q wave and S-segment elevation, or perform a direct ECG over the posterior wall of the heart by moving chest electrode V4 and 5 and 6 to this position. We'll call it V7, 8 and 9, with V8 at the tip of scapula, V7 just before it and V9 just after it. If we record the ECG from this zone, we will find this mirror image. So this is an important ECG to be remembered in ER. Finally, a different scenario, we have a 40-year-old female patient presenting with acute shortness of breath 1 week after cesarean section. This scenario is a scenario of pulmonary embolism. So what is the signs of pulmonary embolism that might be striking in the ECG? In pulmonary embolism, there is what is called S1Q3T3 sign. That means we have a deep S wave on lead 1, a Q wave and the inverted T in lead 3. This is called S1Q3 and T3. We might also have sinus tachycardia. The third thing is Q and tall R wave or QR pattern on AVR. This denotes right ventricular strain. And the inverted T in the precordial leads cause V1 and V2 and V3 are recording electricity from the septum and the anterior wall that are partially affected by the right ventricle. So overload over the right ventricle cause T wave inversion on the right precordial leads. All these signs are signs of acute pulmonary embolism, should be taken in consideration. Then we move to the second scenario, which is arrhythmia scenario. Patient presenting with palpitation. How to approach arrhythmia rapidly. starting with slow heart rate, looking then on the B wave QRS relationship. If we have progressive prolongation of the BR interval followed by a dropped QRS beat, this is called type 2 second degree Mobs type 1 heart block. If we have multiple B waves followed by QRS complex, that means that there is B waves that is not conducted with fixed BR interval. This is called second degree heart block Mobs type 2. If we have complete loss of the BQRS relationship in a patient with bradycardia, this is called complete EV block or third degree heart block. Then if the heart rate is normal and BQRS complex relationship, we have multiple B followed by QRS, this will denote atrial flutter. If we have absent of atrial activity or absent B wave with irregular relationship, this will be atrial fibrillation. The third possibility is tachycardia. Then we will look into the QRS complex to distinguish between two large differential diagnoses, narrow complex tachycardia and wide complex tachycardia. Starting with narrow complex tachycardia, looking at the rhythm. If the rhythm is regular, then we will look for the third point, which is the BQRS relationship. If we have multiple B wave followed by QRS complex, this will be atrial flutter. Again, if we have QRS followed by B wave or no B wave at all, this will diagnose supraventricular tachycardia or SVT. If we have irregular rhythm, then if there is no atrial activity, this will be atrial fibrillation. If we have multiple B wave followed by QRS complex, this will be atrial flutter with variable atrioventricular nodal block. Regarding wide complex tachycardia, if the rhythm is regular, the two broad differential diagnoses are ventricular tachycardia in 80% of patients, and in 20% of patients this might be supraventricular tachycardia with wide complex due to bundle branch block. If the rhythm is irregular, this also might be atrial fibrillation with Wolff-Parkinson-White syndrome or AF with bundle branch block. So we will move across all these categories right now, starting with this ECG of 33-year-old athlete coming for routine pre-participation ECG assessment. If we look here, we have irregularity in the heart rate, but it is fixed, and we notice that we have what is called a group beating, a group of beats followed by a dropped one, a group of beats followed by a dropped one, and the patient is slightly bradycardic. And if we look at the BR interval, starting at this one is normal, this become prolonged, much prolonged, then a dropped B wave. Again, BR interval progressive prolongation followed by dropped B wave, and the QRS complex is narrow. So we have a progressive prolongation of BR interval followed by dropped B wave. This gives the diagnosis of Mobs type 1 as we see from our algorithm. Second scenario is a 73-year-old lady presenting with syncope. If you look at this ECG, it is bradycardic. We have multiple B wave followed by single QRS complex, multiple B wave QRS complex. That means that this B wave not conducted, then a conducted one, a dropped one, then a conducted one. In a manner of H2 beats, only one is conducted, and the BR interval is fixed. QRS complex is narrow. Back to our algorithm, we have a bradycardic patient, multiple B wave followed by a QRS complex with fixed BR interval. This patient has second degree Mobs type 2 heart Third example, 75-year-old gentleman presenting to emergency with delirium. If you look at this ECG, this patient is bradycardic. We have multiple B waves followed by QRS complex. But if we look at the B-QRS complex relationship, it is not fixed, and there is complete dissociation between the atrial activity and the ventricular activity. This B wave is too short to be conducted here. This not followed by QRS complex. This variable PR interval, again variable PR interval, not conducted. Not conducted with a variable PR interval, not conducted, variable PR interval, B wave on the middle of the T wave, non-conducted, B wave. It is difficult to create this QRS complex because it's too short PR interval. So we have complete loss of associations or harmony between the atrium or ventricle. So this patient has complete heart block or third degree heart block. There is complete AV dissociation. And when back to our algorithm, a bradycardic patient with loss of BQRS relationship, third degree or complete AV block. The 77-year-old female patient presenting with palpitation, commenting on the rate. The rate is about 70. Let's calculate it. This is a 3-second interval that we explained before. So if we calculated the number of QRS complex in 6-second interval, 1, 2, 3, 4, 5, 6, 7, multiplied by 10, so the heart rate is around 70 in this patient. The rhythm is frankly irregular. The BQRS relationship, actually we don't have a B wave, we just have a fibrillation waves like this one. QRS complex is okay, so we have a normal rate, a regular rhythm with no B wave and narrow QRS. According to the algorithm, we have a patient with atrial fibrillation. Again, 60-year-old female presenting with palpitation, commenting on the rate. Rate is around 70-75. How we calculate it? The number of large square between two RR interval, 1, 2, 3, and 4. 300 over 4 is 75 beat per minute. The rhythm is regular. There is a regular interval between each R and the following R complex. The BQRS relationship, we have multiple saw-shaped B waves followed by single QRS complex. QRS duration is slightly wide. So according to the algorithm, we have a normal rate, regular, with multiple B waves followed by QRS complex that is called atrial flutter. This 20-year-old female patient presented with palpitation. Regarding the rate, the heart rate is very rapid, around 170 or 80 per minute. The rhythm is regular. BQRS, if we look at first time, we don't see any B wave. But if we look carefully at the terminal part of QRS in B1, we will note a small notch that might be a B wave after the QRS complex. The QRS duration is narrow, so we have a narrow complex tachycardia. B wave is not seen or might be seen after the QRS in V1 and regular rhythm. So according to the algorithm, we have a narrow complex regular tachycardia with QRS followed by B wave, or even if we don't see it, no B wave, this will be supraventricular tachycardia. There is multiple types of supraventricular tachycardia, but SVT is okay for provisional diagnosis. We have this 55 male patient, non-ischemic heart disease, presenting with palpitation. So commenting on the rate, this is tachycardia on a rate more than 200, around 150 or 60. The rhythm is regular. the BQRS. Actually we can see might be this a B wave coming after the QRS complex. The QRS duration is white, so we has a white complex tachycardia. In 80% of cases, white complex tachycardia is termed ventricular tachycardia, especially in ischemic patients. So according to the algorithm, we have a white complex regular tachycardia, might be VT in 80% of cases, or the other differential is SVT with bundle branch block. How to differentiate? We have this algorithm called the Brugada algorithm to differentiate between VT versus supraventricular tachycardia and bundle branch block. It depends on certain question. If there is AV dissociation, that means that there is lost relationship between the B wave and the QRS complex. If it is lost, that means that the rhythm of the heart is arising from the ventricle, so VT is diagnosed. If not, we move to the next step. If we have initial tall R wave in AVR, this goes with VT. Again, if we don't have, we look at the QRS morphology. If it is looks like a typical bundle branch block, so the probability of bundle branch block is SVT is higher. If it is not look like a bundle branch block that we explained before, so it is most likely VT. Then we have other multiple points, but for the sake of the time and being on the beginning of ECG reading, consider any white complex tachycardia, especially in old male or ischemic patient, VT until proved otherwise. So we have this 25 male patient presenting to emergency with dizziness. We have a very high rate, almost 280 or 300. The rhythm is irregular. We can see B wave clearly, so we can comment on the BQRS relationship. The QRS complex is white. So according to the algorithm, what is the differential diagnosis? We have a white complex irregular tachycardia that is very fast. Taking in consideration the young age of this patient, atrial fibrillation with pre-excitation or Wolff-Parkinson-White syndrome should be considered first possibility. Other possibilities include atrial fibrillation with bundle branch block. But taking in consideration the very fast rate of this tachycardia, this means that this tachycardia is bypassing the AV node, so it passes through an extranodal tissue. This is accessory pathway commonly seen in WBW patient. And finally, an ECG of a 65-year-old end-stage kidney disease patient who missed his dialysis session and presenting with confusion. We have a very wide complex ECG, barely see any B activity. And what is this? This is called sine wave. This is commonly seen in hyperkalemia. So in this scenario, mostly this patient has significant hyperkalemia. Hyperkalemia causes stretching of the ECG. So it causes BR interval prolongation, QRS complex prolongation like this, and might cause T wave hyper acute or peaking of T wave like this patient. So this patient has a life-threatening hyperkalemia and should underwent dialysis after giving membrane stabilizing agents like calcium gluconate. So at the end of this lecture, for more practice, you can visit this useful website. It has a lot of examples of different ECG quizzes and explanation. And finally, thank you.